Good afternoon. Thank you to the Stanford University Department of Surgery for the opportunity to present our work, including our poster entitled Spatial Fidelity of Microvascular Perforating Vessels using Mixed Reality. Breast cancer remains a devastating disease, and 1 in 8 women in the United States will be diagnosed with breast cancer in their lifetime. Despite the success of breast conservation therapy, more than 100,000 mastectomies are performed in the United States every year. Fortunately, breast reconstruction affords the opportunity to restore a patient's aesthetic form and sense of self after undergoing a mastectomy. Generally, reconstruction falls under 2 broad categories: implant versus flap-based reconstruction. While not feasible in every patient, the use of autologous tissue demonstrates improved patient-reported aesthetic satisfaction and long-term durability. But there remain drawbacks to flap-based reconstruction, including increased cost, longer operations, and donor site morbidity. Many of these challenges are conferred by the technical demands of the operation. Much of the complexity of microvascular reconstruction can be attributed to flap harvest, as any dissection must account for anatomic variability and the intricate course of perforating vessels which feed the transplanted tissue. Comprehensive perforator mapping, using any number of radiographic modalities, but most commonly preoperative CT angiography, provides reduced operative times and fewer flap-based complications. Recently, CTA data has been formatted to fabricate 3D printed models of relevant composite abdominal tissue, including the deep inferior epigastric arterial system. These models are used as a readily accessible guide and educational tool for surgical trainees. Concurrently, wearable computing devices have emerged as a promising novel technology to improve surgical education and performance. Specifically, mixed reality devices afford the opportunity to superimpose relevant imaging on a surgeon's native field of view and the ability to manipulate those images to better inform operative planning and collaboration. The promise of mixed reality devices prompted the question, can holographic projections be leveraged to facilitate flap harvest? Using the 3D printed models as a proxy for on-table patient anatomy, we devised an experiment to compare the fidelity of holographic projections against the anatomic model as measured in 3-dimensional space. The first step in validating this technology was to assess the accuracy of these projections as characterized by 3 key metrics: translation, rotation, and scale. Data from 19 CT scans from de-identified patients who had previously undergone autologous reconstruction were formatted to fabricate 3D printed models of composite abdominal tissue and corresponding holographic projections. Measurements were collected by 4 participants, 3 of whom were surgical residents and 1 a software developer. Measurements were taken in triplicate at 8 anatomic points on the 3-dimensional model and from 2 vantage points using the HoloLens. Discrepancies were calculated from differences from corresponding points. Amongst all participants, the median translational displacement at corresponding points was 9 millimeters, 12.1 millimeters, and 13.5 millimeters between the 3D model and Vantage 1 of the HoloLens, 3D model and Vantage 2, and finally between the 2 Vantages respectively. There was, however, substantial variability between different participants regarding absolute translational distance. Perceived differences were similarly dependent on the axis of measurement. Rotational artifact of the holographic projection was negligible, and amongst all participants, measured less than a degree in any axis. Similarly, artifact and scale was perceived at less than 2% change in the dimensions of the original model. From these data, we concluded that HoloLens virtual projections can approximate deep or deep inferior epigastric perforator topography within millimeters of the anatomic correlate. The use of mixed reality shows promise in the facilitation of microsurgical dissection and trainee education. But looking forward, we will need to assess the consistency with this technology when transitioning into the operating room and validate results when comparing the projections with the patient on the table. Thank you very much to all of our collaborators and colleagues.